Dr. Prashant, you can start your session.
Okay, thank you. Sir, चालू करतो आहे starting.
Yeah.
Good afternoon, doctors. Welcome to this webinar on role of Oseltamivir in flu management. This webinar, as you know, is brought to you by Hetero Healthcare, an innovative pharmaceutical company. Hetero Healthcare, the journey began in 1993 with 30 years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is the largest closed health pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs and FDFs in the world and has Asia's largest API manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation, has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirus, offered Oseltamivir, favipiravir, and remdesivir to the patient, because of which in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got Dr. Prakash Vaidya as moderator. Welcome, sir. Welcome, Dr. Vaidya. And speaker, Dr. Mukesh Sanklecha. Welcome, sir. Dr. Prakash Vaidya is MD DCH with Diploma in Pediatric Sleep Medicine from University of Colorado. Sir is attached to Fortis Hospital, Mumbai and Child Health Clinic, Mumbai. Senior pediatrician with special interest in pediatric pulmonology. Joint National Convener, Asthma Training Module, Revision 21-22. Co-convener and Writing Committee member of Under 5 Wizards modules of IIP. Writing Committee member of Writing Antimicrobials Responsibly module of IIP. National Trainer for IIP and TB module, NRC, CUF module, etc. Sir has got many presentations as faculty at IIP and other platforms. Dr. Vaidya has been past president of IIP Thane branch and has 5 index publications, 1 textbook chapter. Welcome, Dr. Prakash Vaidya, once again. Dr. Mukesh Sanklecha sir is consultant pediatrician attached to Bombay Hospital Institute of Medical Science, Mumbai, Safi Hospital, Mumbai, and has been in practice for past 30 years. Sir, the passion of Dr. Mukesh Sanklecha include pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching, of course. Sir has more than 45 publications in index and Indian and international journals, has been faculty in a large number of national and international conferences, guide for MD pediatrics for past several years. Welcome, Dr. Mukesh Sanklecha. And sir, I hand over the session to Dr. Vaidya for further deliberations.
Thank you, Dr. Prashant. We will start. A very good afternoon to all of you, and thank you, Dr. Prashant, for that introduction. So we'll be starting a discussion. My co-discussant is Dr. Mukesh Sanklecha. But before we actually go into the case-based discussion, I'm going to present a few foundation facts about the disease, the virus, and the antiviral. So first of all, we know that influenza is a very, very widespread disease. And seasonal influenza epidemics are estimated to cause 1 billion annual cases in the world, out of which at least 5 million are severe, and they are responsible for 300,000 to 600,000 deaths per year. So flu is not to be underestimated as a dangerous disease. The virus, influenza virus, is a single-stranded RNA belonging to the Orthomyxoviridae family of viruses. There are 4 types of flu viruses, influenza A, B, C, and D, of which A and B cause annual epidemics. Type A can also cause pandemics, as we have seen. Type C is a less common disease with fewer symptoms, and type D is only reported in cattle. So the virus of our focus is only type A and type B. Influenza A viruses are able to infect a large range of animal species, including humans, swine, birds, seals, horses. So many types of flu are there. These influenza A viruses are further subclassified into the subtypes according to the combinations of protein on the viral surface. Now, this is a schematic diagram of the electron microscopic photo of the virus. Basically, it is a central core and the surface has got 2 distinct proteins. One is hemagglutinin and the other is neuraminidase. Now, these 2 proteins have a major role. Hemagglutinin is a protein that allows the virus to bind to the target cells and allows the entry of the virus into the target cell. Now, as you know, once the virus enters the target cell, it multiplies, it creates new virions of its own type, and these virions have to be released from the infected cells to further disease. So that is what your neuraminidase does. It allows the release of progeny virus from the infected cells and allows it to go into the circulation. So thus, these are the proteins that are target for antiviral drugs as well as the antigens to which vaccines can be created. Now, influenza A and B, of the A viruses circulating, commonly we have today AH1N1 and AH3N2. Regarding the B virus, it is not classified into subtypes, but into two different lineages, that is B Yamagata and B Victoria. Now, it is found that B Victoria is the one that is circulating, and B Yamagata has hardly been noted in the last few epidemics, last few years in circulation. So WHO has now recommended removing B Yamagata lineage antigen from the seasonal influenza vaccine and make a quadrivalent vaccine into a trivalent vaccine. Is there any data from India? I could find a good data from Haryana in 2025, and it reported an upsurge of influenza cases, especially in children less than 5 years. These kids tested the type of viruses, and almost 45% were influenza B, not influenza A alone. And all these influenza B belong to the Victoria lineage. So our data is consistent with the world data. And of course, 51 cases were small children, 1 to 5 years of age. Now, we all know the symptoms of flu: fever, headache, myalgia, cough, rhinitis, ocular symptoms. Flu is indeed a multi-system disease. It can cause respiratory symptoms like coughing, gastric symptoms like vomiting, diarrhea, joint symptoms, muscular symptoms. It can also cause CNS symptoms like headache and encephalitis, and a nasopharyngeal symptoms causing runny nose, etc. So basically, we all know that flu is just a severe form of cold, but severity is subjective and inconsistent. Now let's take a quick look at the antiviral drugs. The earliest drugs, which were adamantine drugs, amantadine and rimantadine, M2 inhibitors, no longer used because of widespread resistance. So these don't concern us. What concerns us are the neuraminidase inhibitors. They prevent, as we said, the release of virions from the host cell and therefore stop the disease in its tracks. Now, neuraminidase inhibitors are active against both influenza A as well as influenza B virus. There are other drugs like favipiravir, RNAP inhibitor, and baloxavir, a really good drug, but not available in India. So in India, none of these are available except Oseltamivir. The other neuraminidase like peramivir, inhaled zanimivir, laninamivir are not available in our country as yet. So we will be focusing exclusively on Oseltamivir, which is the most widely studied and widely available. Even baloxavir, a newer antiviral, is not yet approved in our country. So Oseltamivir was approved for the medical use in 1999, so 26 years back, and still it is the workhorse for the anti-flu therapy. It is a selective inhibitor of neuraminidase enzyme of the influenza viruses A and B. Oseltamivir is a prodrug which is converted to the active form carboxylate in the liver. What does it do? It prevents the virions from which are the multiplying virions from getting out of the cell, and therefore they halt the disease in its tracks. So with this introduction and a little foundation facts, I will straight away go into our case-based discussion. The common cases that we see, like this is my first case. It's a 2-year-old boy with high-grade fever, cough, cold, who was interfebrile active initially. But now on day 3, he has become lethargic. There is some dehydration. This is the flu season, and clinically it looks like an influenza-like illness. So he is hospitalized. Now, Dr. Mukesh, when you see a child with influenza-like illness, what are the degrees that go through your mind?
So once you see a child who comes with moderately severe upper respiratory or lower respiratory symptoms, your focus is initially on various viruses, be it RSV, rhinovirus, be it the influenza and parainfluenza virus, or be it the adeno and human metapneumovirus. And your sequence of viruses change depending on the currently prevailing epidemic.
Absolutely.
But by and large, these are the viruses we would consider, Prakash.
So do you think that a non-respiratory virus can also be confused with influenza, at least initially?
So, you're asking, Prakash, that could one of these viruses start off with a non-respiratory presentation?
Yes,
Once in
precisely.
a while, yes. By and large, if the gamut of symptoms does not include a respiratory manifestation, I would put these viruses much lower down. But yes, the initial presentation may be so. And sometimes even some of these other viruses, for example, dengue virus may come with just mild respiratory symptoms which may misguide us. So based on the current epidemic, it can happen really, Prakash.
So absolutely, we had an epidemic of dengue and flu, and initial 2 to 3 days, you can actually get confused between the two because both have got high-grade fever. Dengue may also have mild respiratory symptoms, as Dr. Mukesh said. So sometimes you need to be sure. Now, in this child who is admitted, Mukesh, what would be your management?
So as the initial presentation and need for hospitalization is poor oral intake, dehydration, we would
And
supplement
lethargy,
IV.
lethargy,
Pardon?
lethargy.
And
Child is very lethargic and dull.
correct. So basically, with his poor oral intake, his urine output has gone down. He's become dull and lethargic. So you support him with IV fluids, with paracetamol. You give symptomatic treatment, and then you assess whether this child qualifies for any specific treatment, be it an antibiotic if you're thinking of a bacterial infection, or an antiviral agent if that diagnosis is higher up and there is a current prevailing epidemic.
Yeah, so in the current circumstances, a child who starts off with a fever and interfebrile fine and then becomes lethargic is a very kind of pointer to flu. And personally, I would definitely put this child on oseltamivir and then also simultaneously send a nasopharyngeal swab for flu so that we know the way ahead. Would you agree with me?
Fair enough, Prakash. Absolutely.
Mukesh, how do you distinguish between, is this child severe or non-severe? And how do you distinguish between severe versus non-severe flu? What are those red flag signs?
So the reason why we need to classify them is number one, for need of hospitalization, number two, for need of investigation, and number three, for need of initiating specific therapy. So if you have a child who has a very poor oral intake, is listless, apathetic, he's tachypnic, his vital parameters are haywire, there is tachycardia, there is tachypnea, there is desaturation on the pulse ox, or there is some other system involvement which tells you that this child is more than just slightly unwell. So these are the red flag signs that would warrant A, hospitalization, B, further investigations, and three, empiric initiation of treatment.
Right. So WHO defines severe influenza as per serious illnesses caused by flu virus like sepsis, septic shock, severe pneumonia, acute respiratory distress syndrome, multi-organ failure, and exacerbation of chronic underlying disease. As you rightly said, these patients need hospitalization, may need oxygen, mechanical ventilation, or vasopressor. So absence of any criteria of severe disease means it is non-severe influenza. Also, WHO, the guideline mentions that patients with novel influenza A, which are unknown risk, should also be considered severe influenza and therefore should be started on antiviral oseltamivir right away. Let me take one more case, which was a little similar but little different in some ways. This was 18-month-old Shlok. He had a past history of a typical febrile seizure. On day 2, he was brought to my clinic and he had just had one more febrile seizure in the morning. But by the time he came, he was active. So I sent him home on symptomatic treatment. Mother continued to text us that intermittent high-grade fever is there, but child is happy and playful in between. And next day, he has a third seizure. He had a second seizure of this episode, the third in all. And this time, because of the repeated seizures, we have admitted him. So here, Mukesh, in the flu season, which we are having and which we had in a big way, would you give him oseltamivir upfront?
So let us see in which group of patients you would give empiric oseltamivir.
Yeah.
You would give it to patients who are hospitalized because of flu-like symptoms, or patients in the outpatients with high risk. So this
Right.
this is a child who has been hospitalized for a non-respiratory indication. Your indication for hospitalization is a febrile seizure,
Right.
and so this does not by guidelines qualify for
Yes.
empiric oseltamivir. This is also unlikely to be a influenza-induced CNS manifestation, because clearly you're telling me that
Child is active.
this child is well between these
But I'll give
seizures.
you another perspective. This is a child who is getting constant high-grade fever, which is triggering of a seizure. So to me, there is some reason that, okay, I know this is viral, so why don't I treat that viral with a specific antiviral drug? So in this situation, though absolutely by a legal thing, you would say this is not flu, I would still start oseltamivir, because this is a child who is, I don't want him to get constant high-grade fever, and I think we are justified in starting. Of course, I will send a swab and take it from there. So we did send a swab and we found influenza A, H3N2, H1N1 not detected. So this was a real unusual case just about a month back, but I don't know what flu was it. But I take your point, Mukesh, that going by the guidelines, it is a very gray area to start. Same patient, active when you saw, intake not normal, but okay, passing good amount of urine. So are there any OPD indications for oseltamivir? What do you think?
So if this child was, the primary presentation is febrile convulsions, and he's a otherwise well child, he would not
No,
qualify
I'm
for.
talking of any child in general, Mukesh, not this particular
Okay.
child. Yeah.
So a child who's having mild symptoms comes to the office and has no potential high risk factors does not qualify for empirical oseltamivir.
Yeah. So I think oseltamivir is given empirically as per WHO guidelines in either high risk children or, interestingly enough, with high risk contacts. That means a child who has high risk, and I'll just get Dr. Mukesh to tell me which are the high risk children, but those are the ones who have a high chance of getting hospitalization during influenza, and similarly high risk contacts. So Mukesh, could you just run me through the high risk children that qualify for oseltamivir upfront?
And so, Prakash, if you have a preterm child who has been ventilated, has chronic lung disease, you have a patient with a congenital heart disease with left to right shunt and increased pulmonary blood flow, you have a nephrotic syndrome, you have a sickle, you have a patient with primary or secondary immunodeficiency, you have a child whose man is a malignant child, is having malignancy, he's on steroids, you have a child who's also uncontrolled asthma or some other chronic pulmonary lung disease. These groups would qualify. In addition, as you rightly said, even if the child is not at high risk, if there is a family contact in the house who's at high risk, for example, one of the parents or grandparents is more than 65 and at risk for severe flu, or there is a patient with malignancy in the family who's on steroids, or there is an immunocompromised person in the house who is at high risk for severe influenza if he or she gets exposed, then that primary child would warrant oseltamivir therapy, not for his own sake, but for the contact's sake.
That's a very interesting concept, that you need to protect in high-risk children as well as children with high-risk contacts. Now here this is the chart from Up to Date. It mentioned asthma on the top as a chronic pulmonary disease, and therefore you need to start oseltamivir. But the WHO guidelines do not tell us that asthma is not one of those patients for high risk for hospitalization. So you don't qualify it as high risk. But then this is one of the gray areas. The other interesting thing is extreme obesity. BMI more than 95th percentile in children, and you believe me, we do see such children in a big way nowadays. So
Oh,
these
yes.
kids definitely qualify for upfront oseltamivir because they are at high risk. This is exactly what we saw in COVID times, that a person with obesity ended up getting a severe COVID and a higher chance of getting ventilated.
Sure.
So, Mukesh, you told us that when you give oseltamivir, high risk parent, or high risk children and high risk contacts. What I want to know is, if a patient starts with a non-respiratory presentation, have you ever used oseltamivir in such a case?
Ideally, if there are no respiratory symptoms in the child's presentation, the bug being influenza would be much lower down. I would not give this child initial empiric oseltamivir. However, if it's a moderate or severe presentation, I would investigate this child, and if he comes back flu positive, then obviously I would start it. But empiric initiation in a child who has no respiratory symptoms would not be on my cards.
Absolutely, because sometimes flu does start with a diarrhea, but eventually you're going to get respiratory symptoms like cough and cold. So strictly non-respiratory, unlikely flu, but cannot be ruled out because this may be the initial presentation. By the way, do you always do a flu swab either before therapy or after starting therapy? What is your policy?
So you would do a flu swab for every hospitalized child, be it
Yes.
in the ICU, be it in the wards. And interestingly, you would initiate oseltamivir pending investigations. In direct contrast, if that child is a stable child who's come in office practice, you would almost never do a swab to confirm. Your decision would be based on whether child is high risk or not high risk.
So
In
swab
terms of
actually is the cost that is also a restricting factor. So I, like you, I also do not do a flu swab in OPD patients, but I do it in all indoor patients for starting, right?
right,
But now our patients have different thoughts because somehow they trust lab reports in a very big way. So I have had patients, I'm sure even Mukesh, you must have had, that a patient has the child has fever, and 2 days later the parent comes with a report which he has on his own record done, no matter what the cost. So this also happens, right? Do you get this
absolutely,
experience? Yeah.
you bet.
So what do you do if the swab comes negative? What is your policy?
So actually, it's a difficult predicament. We know
Yeah.
that when you do it's a PCR test with extremely high sensitivity and specificity, a sensitivity of more than 95% and a specificity of almost 99 to 100%.
Right.
So ideal situations, a swab that is collected properly in the first few days of illness when the shedding is maximum should be reasonably strong ground for us to give and withdraw therapy based on the test. But we know that in real life situations, the the conditions may be suboptimal in terms of the testing, both the technique and the timing. So, so therefore, if you are confident that your swab has been taken properly and it has been taken at the correct time, then you can withdraw therapy. But if you're not sure of the testing conditions, then probably in the high flu season, you would continue oseltamivir.
I think it's a decision on case to case basis, because if the child is not cooperative, or the resident or whoever is collecting is not very meticulous, you may get a false report. So, but WHO guidelines say that if the swab is negative, you can stop the treatment. But as there are always ifs and buts, so I think you must take a decision on a case to case basis.
Also, Prakash, if you get an alternative diagnosis, suppose I'm doing a multiplex PCR and I find a RSV has come up and the flu is negative, then I
Correct.
may actually pull out the oseltamivir.
Absolutely. But multiplex PCR, the problem is that the cost is much higher
I know.
than a flu swab. So if the cost is not an object, I completely agree with Mukesh. I'm suspecting flu and I do a multiplex PCR. I've started oseltamivir upfront. And if it's not flu, I know that the sample was good because it did isolate RSV. I'd probably not, I'll probably withhold. But again, the caveat to that, Mukesh, is that I have had a number of patients who have had both RSV and flu in the last season. Because in my hospital, we get an extended flu swab which contains influenza A, influenza B plus RSV. So I think it's a case-to-case based decision, right?
Fair enough.
Now, choice of antiviral therapy, I'm just showing you this chart from UpToDate, where they have said that children with severe illness, non-severe illness, everywhere the choice is oseltamivir. Above 6 years, it is oral baloxavir, but not available in our country. And above 7 years, it may be inhaled zanimivir is an option. So for us, none of them is available. So our only choice is oral as oseltamivir. Alternatively, peramivir is also not available. So let me take one more case. This is a mother who breastfeeding a child. The baby is now 6 weeks old, and this mother has moderate to severe influenza symptoms. So her treating physician wants to start oseltamivir, but she is concerned about the baby, and she calls you up. Okay, Dr. Mukesh, is it safe for my baby if I take oseltamivir? What would you say?
So there are double reasons to initiate oseltamivir in the mother. Number one is obviously for her moderate symptoms, for her to recover quickly. But equally importantly, we have this 6-week-old baby who is at high risk for contracting influenza. And we know that the smaller infants, babies below 2 years, are at risk for more severe influenza. So in terms of benefit, it benefits the mother, but it also benefits my patient, which is a 6-week-old baby. Now,
Right.
if the mother is concerned because she wonders whether drug is safe for the baby because she's breastfeeding. So we know that oseltamivir has an excellent safety profile, even in pregnancy, let alone during breastfeeding. So absolutely safe. And in fact, I would reinforce her physician's concept of treating the mother quickly, and we hope that that will ensure that the virus is not passed on from the mother to the baby.
As you said, it kills two birds with one stone. It protects the mother. It protects the high-risk contact as well, right? So there
Right.
is no contraindication to giving. But if the baby needed, does the baby need either prophylaxis in this case? Does he need prophylaxis upfront? Mukesh, what do you think?
So if you look at the risk profile, the answer is yes. That such a small baby, if she were to contract influenza, it would be a scary thing. But yet at the same time, in terms of the approval to use it, we normally use it only above 3 months. So in that way, she would not qualify for prophylaxis.
Correct.
But if she became symptomatic, I would keep a close watch and a very, very low index of threshold for initiating oseltamivir in her were she to become symptomatic.
So the youngest age to give prophylactic treatment is mentioned in the documents as 3 months. But if the baby is small, as low as 14-day-old babies, you can start. And exceptionally, you can start even in younger babies if the condition so warrants and if the child is really critically ill. So this is again a table from up to date on prophylaxis, treatment or prophylaxis. So term infants with known body weight below 3 months, prophylaxis not recommended. But 3 months onwards, it is recommended. And this is the dosage, 3 milligram per kilogram, orally once daily. In term infants, whose body weight is not known, they have mentioned the doses. Now look at preterm infants also. So any preterm infant 28 weeks and above, you can safely give oseltamivir 1 milligram per kilogram per dose. The dose is low, 38 to 40 weeks, 1.5 milligram per kilogram, and thereafter it is 3. So even prematures, this drug is very safe. However, if the baby is below 28 weeks, then a consultation with a pediatric ID specialist is recommended. So by and large, there is a blanket approval to give oseltamivir even in young as well as preterm infants, with some minor exceptions like this. So
Prakash, go back to that chart. Very
Yeah.
interesting, no? They mentioned that prophylaxis not recommended except in critical situations.
right.
So I think
What is the critical situation?
yeah, I was wondering while you were reading out the chart, in what, Prakash, let me ask you a question. You've been asking me too many questions. So where would you start a prophylaxis in a not ideal recommended baby? So below 3 months.
No, I think, Mukesh, if there is an intercurrent illness to the baby, suppose the baby is already very sick due to some other reason, and now he is exposed to flu, there I think this would be a critical situation. Suppose the baby just got operated for, let's say, a diaphragmatic hernia or something, and the baby is already immunocompromised due to some other reason. Then I think that is what they mean, that this is a critical situation where you will give prophylaxis as well, because you don't want a second infection there. This is the way I interpret it, yeah.
Sounds good, Prakash. Yes.
So this is a 11-year-old boy, fever, vomiting, cough, cold, altered sensorium since 2 to 3 days, clinically query encephalitis, X-ray shows haziness on the right lung, child was intubated in our ER, shifted to the PICU. His lumbar puncture was done, the CSF was normal, and the child was started on IV antibiotics after sending blood culture, IV antiviral, that is acyclovir, and other symptomatic treatment. The labs were not very helpful to us. They were quite unremarkable. But the nasopharyngeal multiplex PCR detected influenza A, H3, and 2. The CSF meningitis panel, however, did not show influenza. Now, in this clinical scenario, Mukesh, how will you react to that multiplex PCR? Will you give this child oseltamivir?
So this is very interesting. So his CSF meningitis panel is negative, yet his nasopharyngeal multiplex PCR detected influenza. Now, there are two issues. One is that we don't have a test to detect influenza in the CNS directly. We need to look for surrogate markers.
This point
So-
should be noted that the biofire test in CNS done all over does not detect an influenza virus. Yeah, sorry.
Correct. So your panel, so that explains why your CSF meningitis panel has come negative, and yet your nasopharyngeal swab is positive. Now, so obviously, as a surrogate marker, since there is active influenza in the respiratory tract and child has a encephalopathy or encephalitis, we would say that this is most probably influenza encephalitis or encephalopathy, and treated with oseltamivir. Now, the symptoms could be either because of viral invasion, or it could be an autoimmune manifestation of the CNS to the influenza virus. So
Yeah, the
that
point
would
is that
explain
we
the
don't
CNS.
need to detect the virus in the CSF. This is a good surrogate marker and we treat, right?
Sure, absolutely.
This was the X-ray, and the neurologist reviewed the child, viral encephalitis. Child continued to have fever spikes. On day 2 of the hospital day, this child developed symptoms of acute kidney injury, AKI. Do you think, Mukesh, the flu virus is implicated in this AKI?
So, Prakash, we always teach our postgraduates that viruses affect multiple mucosal surfaces. Cough,
Right.
cold, involves the liver, involves the kidney, it's involving the CNS so many times. So yes, this could be direct invasion of the kidney, which has caused acute kidney injury. Plus, it could also be that this child was ventilated, was hemodynamically unstable, and that led to some amount of kidney injury, which led to this kind of an elevated BU and creatinine and acute renal involvement. Because by and large, drugs will not cause it. Even though the child is on Oseltamivir, we all know that we do readjust doses in renal disease, but
Yes, yes.
per se, drug-induced nephritis is very unusual with Oseltamivir.
2 points here. One is that when this patient came, I did look up the literature and I at least found 2 reviews which showed that flu virus can cause AKI.
Sure.
And as Mukesh rightly said, if there is AKI and a high creatinine, you will need to adjust the doses of Oseltamivir as per the charts which are available. So one more question was that this child came to you on day 3. Okay, and they say Oseltamivir is to be usually given within the first 2 days. So do you think that Oseltamivir given at this point will help this child?
So I think, Prakash, that's a very valid question. So there are 2 important messages in this. Number one, when you are in a flu epidemic, don't hesitate to initiate Oseltamivir in the correct indication early, because for the best results, it should be given in the first 48 hours of illness, number one. Number two, what do you do if you have a serious child who comes later? Well, the recommendation is, if the child is clearly improving, you would not initiate Oseltamivir. But here you have a child with a serious illness. So you have a child with CNS involvement, you have a child with kidney shutdown. This kind of a child, you have to give him the benefit of doubt and give him Oseltamivir, however late he may come.
Even up-to-date mentions that neuraminidase inhibitor therapy may be administered more than 48 hours after symptom onset, particularly in hospitalized children. So you can give it late. And I have always made it a policy in the flu season. If I suspect that flu could be somewhere in the picture, I would give Oseltamivir in addition to all other treatment, no matter how late. So it's never too late to give this. So this is the WHO guideline algorithm. Person with suspected or confirmed influenza. Is it severe? And we mentioned the points of severe. If severe, yes, give antiviral. Severe means requiring hospital care. If it is not severe, don't give. But then look at, is the patient at risk of progressing to severe? Yes, give antiviral. And we know who are the patients at risk to progress. There they have mentioned Baloxavir as the choice, but Baloxavir is not available in India. So we go for Oseltamivir. And if none of the above is there, then we will not give antiviral. This is the guideline on prophylaxis, and we'll discuss that in a little more detail. Again, the guideline focuses on 2 things. Is the patient at risk of severe illness? Then give prophylaxis. And was the exposure to a zoonotic virus, which is unknown, not H1N1 and H3N2, but something else from some other creature we do not know. So that would be a point you don't want to take a chance. So there are clear guidelines of the WHO on when to give prophylaxis, and it is to be given within 48 hours of exposure for a period of 10 days. So let's just for the sake of
Prakash, you mentioned prophylaxis for 10 days.
Yes.
I was looking up literature and they said in the real high risk patient who's constantly exposed, the duration is very variable. There have been cases where it's been used for even as long as 6 weeks through the flu epidemic.
Yeah, that's a great point, Mukesh. The standard treatment says that give it for 10 days. I think it is 10 days at least. It doesn't say that if the risk is gone, you can stop it. So the Oseltamivir is such a safe drug, you can give it even for a longer period if the situation warrants. So
Do you think, Prakash, you may ask this question later on, but I was wondering whether prophylaxis is not used at all or significantly underused.
Probably, I think so, that we don't use it often enough. But again, there are clear-cut guidelines. So I think we'll come to that in the little later part of the discussion.
Done.
Right?
Yeah.
So dosing of oseltamivir, just for the sake of just for review, very simple to remember. Adults and those 13 years and over and more than 40 kg, 75 milligram BD, and those below 40 kg, it really depends on the age bracket, the weight bracket. And under 1 year, it is 3 milligram per kilogram per dose, twice daily for 5 days. And above 40 kg, 75, 23 to 40, 60, 15 to 23, 45. This product insert is very easily available, but this is the way to remember the doses. I personally am not able to remember except this 3 milligram per kilogram. So I sometimes consult I do consult the leaflet for that. And for post-exposure prophylaxis within 48 hours, and the dose is exactly the same. The only difference is it is given once a day, that many milligrams once a day and given for 10 days. So your total amount of drug consumed is the same. And as Mukesh pointed out, if the situation of exposure really warrants, it can be for a longer period also. Let me take one more case here. That this is a 6-year-old boy who has come to your consulting, and he is looking a little dull, not really needing admission yet, but he is looking like an influenza-like illness. And you are proposing that we will start oseltamivir. But the mother says, Doc, he has received flu vaccine. You only gave it this season. What is your reaction?
So Prakash, I assume that though he has come to office practice, he has some high risk because of which we are planning to start oseltamivir.
That's right.
Am I right?
Yeah, probably so. Yeah.
Yeah. But the issue is the mother is resistant. That why are you treating an illness for which he has received the vaccine? Now, we all know the flu vaccine is only about 60 to 70% effective in the best conditions. Keeping in mind the antigenic shift and drift of the virus, we are constantly trying to upgrade our vaccine, and yet it is not as effective as a lot of other vaccines. So the message is the child could still get flu despite having received the vaccine. In fact, recently I had a child from Tata Institute of Fundamental Research, a scientist's son was hospitalized with flu despite me having given the flu vaccine. And even before I could go in to counsel him, he had already asked my residents, but Dr. Sanklecha has already given the flu vaccine. How come my child got flu?
Right. So we have to be very sure that they are aware that there is at best in all cities a 70% effectivity, usually less than that. So your 30% of patients who receive flu vaccine are still vulnerable to receiving flu. So starting oseltamivir is not contraindicated just because he has received flu vaccine. Also, the point is, when has he received? The parent may tell you he have received, but he might have received in the last season and not this season. So in this case, will you do flu swab first, Mukesh?
No, you would not. This is an office-based indication where you initiate oseltamivir based on high-risk profile or a high-risk contact profile, and you don't need to confirm.
Correct. So in short, treatment should be initiated regardless of the patient received seasonal flu vaccine, should not be delayed awaiting the results of viral testing to confirm influenza. And one more thing is that many times COVID or RSV, they may coexist. So positive one test does not again mean influenza unless influenza has been expressly excluded. Sometimes you may just do a COVID PCR, now not any longer, but a COVID PCR positive does not mean that the child does not also have influenza. So this is all points to be kept in mind. Mukesh, we all have been using a lot of oseltamivir. Do you get adverse reactions? What is your experience?
Actually, I think oseltamivir is a drug that is beautifully tolerated with very, very few side effects or adverse effects. And by and large, nobody comes back with any complaints. We know that it can cause gastritis, it can cause a gastroesophageal reflux. But by and large, that is more of an exception than the rule. So I have virtually encountered no mild or severe side effects with this drug.
So I think I agree with you. I have encountered sometimes patients getting vomiting with that, but then there are patients who vomit every drug. So if he vomits, I just tell the parents that do not, if anything vomited within half an hour of its administration has to be repeated. And rarely there is GERD. So sometimes you need to give PPI, but PPI is not the standard of care to be started in each and every case with oseltamivir, as some people are prone to do.
Spot on.
So in Japan, they have found post-marketing reports with serious, because Japan uses a lot of neuraminidase inhibitors, and they found that in some cases there were neuropsychiatric effects. But again, different studies have not shown the causality, and it is also thought that some of these neuropsychiatric events may be related to the flu virus and not the molecule of treatment. So many times our patients have a question that, doctor, when can I send the child to school after an bout of flu? So what do you tell them, Mukesh?
Yeah, Prakash, so the viral shedding is max in the first 48 hours, but it continues up to as long as 5 days. So
Right.
ideally, the child should not go to school for 5 days. But
Which never listen.
yeah, it's
Yeah.
like our chicken pox does not go for 5 days. So because he's at risk of
Yeah.
of transmitting it to other students, and
Right.
and the infectivity rate is very high. No, with Prakash, with influenza,
Yeah.
the bug in epidemics can hit 40-50% of the population. So it's
Right.
a rapidly spreading bug. So I would not send it for several days.
But parents don't listen. So that's why the CDC has come out with a kind of ground reality taken in mind that if a child has an influenza-like illness, he should not go for 24 hours after their fever has resolved without antibiotics. So once 24 hours have passed, he has not needed an antibiotic, then you can send him to school, is what the CDC guidelines are. Mother says that I have given Oseltamivir as per your advice. Can I send a child earlier to school because of that? What do you say?
It makes rational sense, no, Prakash? If you're giving Oseltamivir, it's an antiviral drug. It would reduce shedding and
Right.
reduce duration of symptoms. So that
Right.
child would recover faster and go to school faster. But
And
I
he
think,
must be a focus of infection. I mean, cease to be a focus of infection faster.
yeah, so I would be more comfortable sending a child on Oseltamivir to school earlier than a
Right.
child who is not on Oseltamivir. But
So sorry.
But as
Yeah.
you said, Prakash, they don't listen to us.
They
So
don't listen, they send on day 2. But CDC has said, regardless of the child receiving antiviral, wait till the child is afebrile for at least 24 hours. And in that 24 hours, no anti-fever drugs have been used. So many times what happens is that Oseltamivir, many times in the flu season, we don't know whether the patient has got a bacterial infection or a viral infection. And many times people tend to overuse antibiotics in a sick and febrile child. So do you think that diagnosis and management with Oseltamivir helps in antimicrobial stewardship? What is your experience?
yeah, Prakash, I think so. Because if it's a hospitalized child and we don't have a diagnosis, we initiate empiric therapy. And if we get a specific diagnosis like influenza, that the willingness to withdraw an antibiotic is much higher.
Right.
Or if he comes with a diagnosis of influenza, the temptation to use an antibiotic is that much lower. So yes, I think in the hospitalized child, definitely.
So this is the same.
In office practice also, where I'm confident that this child is in a flu epidemic with respiratory symptoms, I will not give in to pressures from the parent to give an antibiotic and get the child recovering faster. I will tell them that we are seeing flu and I would be happy to offer you Oseltamivir since your child is high risk. And I might get away not giving an antibiotic despite parental pressure. So yes, it does help.
Does help in AMS. I'll give you an example. But yeah, so I had this child with a 10-year-old boy with presentation of day 2, fever with rigors, headache. Child was in my OPD and my resident doctor was with me. And she said, sir, this is tonsillitis. But when I looked at the child, there were tonsillar crypts and there was no halitosis, no lymphadenopathy. It wasn't even looking like a bacterial infection. So I told the parent, I'm not going to give antibiotic, but the parent was insistent. So what I did was I told him, you'll send a flu swab and we'll start Oseltamivir because I think this is an influenza-like illness. And sure enough, we got the flu swab which showed influenza A. So here, the doing the swab and starting treatment helped me in AMS, and there are many cases like this. So Mukesh, but on the other hand, does it mean that we use sometimes Oseltamivir too much, too indiscriminately?
I think so. For treatment, there are pockets of overuse and pockets of underuse. We still have several doctors who are hesitant to use the drug. We have some pediatricians who tend to overuse it a little bit. But by and large, I think there are both spectrums. But prophylaxis is definitely underused, no doubt about it.
Right. So I'll give you one more case of an 11-year-old girl with fever for 2 days, high grade, no chills or rigors, difficulty in breathing, and post-tussive vomiting, bronchospasm. And this patient was admitted last month with influenza A elsewhere. So this time the child was very sick. We had to give HFNC support, ceftriaxone, injection dexamethasone, Fluir. Oseltamivir, azithromycin, and nebulization. Now, the point to tell you is that this child's swab again came positive of influenza B plus RSV. So this is the child who had uh, influenza A once and now had influenza B. So the moral of the story is that even if there is influenza A, you can still get influenza again because you don't get immunity against the other viruses, and therefore oseltamivir is to be given on indication. Just because you gave it last month does not mean that you may not need it again, especially in a scenario like this. This was the child's. I'll ask Mukesh one more, involve Mukesh with one more case story. This was a 10-year-old child, Arjun, who had asthma but well controlled on ICS. It was the flu season. He had influenza-like illness symptoms. And this child, would you give oseltamivir upfront if he came with ILI, considering that he is a child on asthma?
So though he's an asthmatic, he's well controlled. His pulmonary status is very similar to yours and mine's. So ideally, this child would not classify as high risk for using oseltamivir upfront, despite the slide from up to that he showed, which talked about asthma being a high risk for treatment. If the same child was poorly controlled, then I would strongly consider oseltamivir, but not a child who's upfront well controlled on ICS.
So I think it really depends on a case-to-case basis, because the up-to-date guideline did say that asthma was a high risk, but WHO says it is not. So I think, as Mukesh says, if it's uncontrolled, I don't want him a double whammy of getting influenza. So I give it. But if he is well controlled, then he's like any other child. Now, Mukesh, I ask you, what if Arjun is obese? What happens to the risk now? He's at a 95th percentile in terms of weight.
Okay, so now you are putting up another risk factor, which by itself classifies him to become high risk.
Right.
So even if he is well controlled but significantly obese, above the 95th percentile, then he would qualify for oseltamivir just based on this. Though he is 10-year-old, well controlled but obese, so you would give him oseltamivir.
So obesity is a clear risk factor, and I would give. But now in this child, somehow we did not give oseltamivir, and the child did well. He was better after 2 days. He was, though the fever had not gone, he was looking low grade, he was looking normal. But then the parents told me that a grandmother is also ill and her flu swab showed influenza B positive. Now, does it change anything? Does Arjun need oseltamivir now? What do you think?
Now that's a sorry. Now that becomes a little tricky, Prakash. The child is better, so he does not recover oseltamivir. The poor grandmother has got hit. And then Prakash, we just go back and think, have we taken a proper history? Should we have picked up the high risk contact of Arjun and given Arjun oseltamivir initially itself, so that the grandmother would have not suffered?
Right. So I think we ignored that he had a high risk contact, or we were not aware. But looking from Arjun's perspective, the grandmother is now being treated and Arjun is recovering. He probably doesn't need it. He surely doesn't need it this time.
Perfect.
So, do you ever have an experience where you use an antibiotic along with oseltamivir? I mean, what is your policy there?
Yes, Prakash, I think we always use empiric polytherapy in the very serious child. Like your child who was serious on the ventilator, you started multiple therapies. So you would initiate antivirals and an antibiotic if the child is really serious. Plus, you have initiated oseltamivir, child is not improved for 48 hours. You start wondering, is there a concomitant bacterial infection? We know strep pneumonia, strep pyogenes, staph aureus are notorious, and influenza patients tend to deteriorate very fast if they had a superadded bacterial infection. So you need to keep your antenna up. Furthermore, if a child has improved on oseltamivir, goes downhill again, you wonder what is happening. Has he had a hospital-acquired infection? Also, if the child localizes the infection, develops a nice pneumonia, a good lobar pneumonia, he has his CRP going up, his leukocytosis there, you may be having a procalcitonin going up, then you would wonder, is there a bacterial infection lurking somewhere? Then you will be justified in giving an antibiotic.
So flu and other bacteria, flu and bacteria can be like two possibilities. One is it can be a co-infection or it can be a secondary infection. Now with flu is known to be a pathfinder for pneumonia to occur. So when a child gets secondary, he seems to be improving on oseltamivir, now starts getting fever all over again, his CRP is rising, his white cell count is rising, or as Mukesh said, there is a focus somewhere. then sometimes you know that this is a secondary infection and you will give antiviral along with antibiotic. So there should be evidence of a concurrent bacterial infection, but do not give it indiscriminately. Empirical use for influenza, in influenza, antibiotic is not required. And exceptions include suspected bacterial co-infection like persistent fever and neutropenia. These are the WHO guidelines. So now, Mukesh, we're running out of time, but we'll quickly talk about oseltamivir prophylaxis. Now, if you had a child whom you admitted for flu, you gave oseltamivir, it was confirmed influenza A or B. Now the parents are attending the child, they are with the child all the time. Would you give them prophylaxis?
Only if they are at high risk.
Right. So, like,
A high risk, like suppose the mother is on steroids, or the father has a chronic lung condition, or it's a leukemia on chemotherapy, or it's a immunodeficiency, or it's an elderly parent who's more than 65 years, which is unlikely, of course. So any risk factors which make the parent prone to severe influenza, I would give prophylaxis.
so now the parents are all fine. They are young people. They have no intercurrent illness. But now they are worried that the grandparents are home. And do we give prophylaxis to the grandparents so that they don't get the disease from the child?
Oh,
What do you
yes, you do. Whether they are high risk or low risk, because age itself is a high risk above 65.
So you will give prophylaxis to the
Yes.
grandparents.
Yes.
And if they said that, okay, now we are taking the child home, but he's got a younger sister who is about 3 weeks old, will you give prophylaxis to that child?
So 3 weeks, once again, like you had an initial case, he's at
Yes.
extremely high risk of severe influenza, but he does not qualify for prophylaxis in terms of age. So what you would recommend is, you would recommend separation, good hand hygiene, use of the mask, try to physically prevent the younger sibling from getting the bug.
Absolutely. So prophylaxis is only for individuals who would have extremely high risk of hospitalization if they contracted influenza, should not be given arbitrarily, and post-exposure prophylaxis should not replace influenza vaccine. Now, if you had a child with a croup-like picture like I had, and the child swab was done, multiplex PCR, a little sick child was admitted, and it shows para-influenza virus. Now, my resident doctor frantically calls me that this is para-influenza. Should I start oseltamivir? What do you say?
Yeah. No, so unfortunately, oseltamivir works only against influenza, not
Right.
against para-influenza.
Just because there is influenza in the name does not mean that oseltamivir is required here. Okay. Now, what are the contraindications to oseltamivir therapy in your practice, Mukesh?
I think virtually nothing, unless the first dose of oseltamivir has led to anaphylaxis or a severe allergic reaction. By and large, oseltamivir is beautifully tolerated. Of course, it's an oral drug, so there is any contraindication to administering oral medications.
Right.
Then you would not use it, but otherwise, no.
Yeah,
Even
maybe
if you have-
gastric bleeding or bowel obstruction. But again,
Correct.
these are relative contraindications because we do not have an option in our country of either IV or inhaled. So ultimately, you'll have to get over this and give him oseltamivir at some point of time if he requires it.
Correct.
So, are there any drug interactions with oseltamivir in your experience, Mukesh?
No, I think virtually none. It can go with most drugs, or all drugs rather.
Right. But one thing is that dose modification is needed in renal insufficiency. And there is always a confusion that my patient is recovering, he's on oseltamivir. When can I give the flu vaccine? So what is your perspective on this?
In most cases, you would even normally delay vaccination until the child has recovered completely. But
Right.
by and large, since it's a killed vaccine, there is no contradiction to its use. And quickly after the child recovers from his flu infection, he can be vaccinated.
Yeah. So remember that if the child has received oseltamivir, killed vaccine can be given any time. For the live vaccine, you have to wait for 48 hours after oseltamivir therapy. And if you happen to give oseltamivir 2 weeks, within 2 weeks of giving the live vaccine, that live vaccine becomes invalid because it's not going to work. So, of course, we don't get live vaccine in our country so readily
Exactly.
patch this time. But this is the contraindication for live vaccine. With kill, there is absolutely no gapping, nothing required. So I think we are running out of time. So we've had a very discussion covering as many bases as possible, and Dr. Mukesh has been really helpful with all the information that he gave us. So to sum up, oseltamivir is currently the only anti-influenza drug available in our country. So we do not have an option. It's a very useful drug in treatment and prophylaxis, but usage must be timely and with proper indications. And also one must guard against indiscriminate use. With that, I stop sharing my screen. Thank you very much, Mukesh, for this, and thanks, Hetero, for this.
Prakash, excellent set of cases and
Sir,
superb
there have been a couple
clinical
of questions
security.
from the audience.
Yeah.
Specifically asking any drug interaction with antihypertensive drugs and drugs used to control diabetes.
Those are not mentioned anyway. That is not mentioned.
Exactly.
Yeah.
And one question is that after RCT, can we prescribe it?
After?
RCT.
I didn't understand.
The question is after RCT, can we prescribe it?
RCT is what? Randomized control trials.
I suppose I do not
What is
know.
RCT here?
Anyway, if I get some more clarification, I will forward.
Sure.
Yeah. Okay. Thank you so much, sir.
Okay.
Yeah. Thank you so much. It
Thank
was
you, Prakash.
nice, as usual, nice, in-depth discussion on both influenza and do's and don'ts and management with Oseltamivir. Thank you so
Maybe
much. I'm sure the
RCT.
audience has benefited out of
Yeah, what
it.
is RCT?
Yeah, maybe RCT is root canal therapy. Maybe. I don't know. I'm just
I don't think
guessing.
there is any contraindication.
Yeah.
No, you
Should
can
not
use
be,
it.
should not.
No, I don't think. If root canal therapy, no contraindication whatsoever. But I don't know if that is what is meant by that. Yeah.
Okay, sir.
Okay, thank you very much.
Before that, let me wish you a happy Diwali,
Yeah,
Dr.
thank you.
Mukesh and Dr. Vaidya.
Yes.
Happy Diwali and a prosperous New Year. Thank you so much.
Thank
Thanks
you.
all the audience who took time and attended this webinar. Thank you. Thanks, Sanjana. Thanks, Smita. We can log off, sir.
Are we off the air? Can I? I mean, are we no longer live? Hello?
We are live only, sir. We are live only.
Okay. Okay. I just wanted to have a word later on.
Please tell, sir, what is it?
No, if you're live,
We can stop live, Sanjana.